it's great to have the chance to speak with you this afternoon about what I hope is going to come through here in a few moments is something that's a true passion of mine as far as my academic work goes, my research interests. And I'm sure some of you are probably thinking, so what is a mechanical engineer doing in this particular field of work? And you know, it really breaks down to a very simple proposition. Engineering is all about solving problems. We figure things out. That's what engineers do. If it's a medical problem, it's a medical problem. If it's an engineering technical problem, it's all the same thing. It's always about looking at the parameters of the problem, finding all the dots that need to be connected and figuring out how to connect the dots. So engineering in this type of medicine, this type of work is, I think, a very fair thing for us to be involved with. And I'm saying that, you know, specifically to this many students in the audience. And it's great to see so many of the students in here right now that are from my current heat transfer course. This is not going to help your grade 1 iota. So. Terry's already done a good job of queuing up a little bit about me here, and as she mentioned, I'm a GMI alum. So for you students, as most of you already know, I know some of the stuff you're going through, some of the fun and games, the difficulty. I did join the ME faculty as a lecturer back in 1994, and I became interested in pain research about 6 or so years after that, back in about the year 2000. My areas of interest specifically when it comes to pain, and we all realize, of course, there's a lot of different facets and aspects of looking at pain, but I'm interested very specifically in central mechanisms. What goes on when we process pain in our brain, and how do we assess that? And very interesting to me too are neuromodulatory treatment technologies. And of course that's going to be the focus of what we talk about for the most part of the day. I want to start things off with just a quick discussion of where are we at right now in terms of dealing with the state of chronic pain medicine. Now, I don't think I have to tell anybody in here that pain and medicine are two things that have gone together from the dawn of time. It's really the primary issue that most physicians deal with in the general practice specifically. You know, how do you deal with people when they are in pain? And unfortunately, we're a long way into developing greatness in medical technologies, but we're not really doing terribly good in dealing with pain. It's a problem that just persists on, and until very recently, a lot of the answers just weren't emerging. But I think what I'm going to be able to show you today is some reason to believe that we're starting to get a handle on this kind of thing. Chronic pain is a global healthcare crisis, and it's very important that we understand that. We're talking about the type of pain that comes along and just does not go away. The pain that you deal with on a day-to-day basis, and for some people on a monthly, if not an entire lifetime basis. It is a very costly problem. It is a problem that burdens the medical systems of any country in the world. It is, in fact, a crisis, and in 2010, started saying 1910, in 2010, I was around in 1910. In 2010, the National Academy of Sciences Institutes of Medicine came out with a study that was conducted over a couple of year period, and it was a study on the state of pain medicine in the United States. And some of the findings were eye-popping, very revealing. This is new data that's only a couple of years old, but it's beyond what we expected. The Institute of Medicine report in 2010 showed that around 116 million people in the United States alone are affected by chronic pain, and the economic burden on our country as a result of that is somewhere in the range of $565 to $635 billion every year. It's a perpetual spending over and over again. But further to the findings of that, they found that the state of technology in assessing and treating specifically chronic pain remains difficult at best. The findings showed, for example, that current medicines, the typical analgesics that we might treat pain with, ibuprofen, acetaminophen, those kinds of things, that when it comes to chronic pain, these medicines aren't getting the job done. Poor outcomes in chronic pain. And a key paradigm shift emerges from that, and specifically, the intent of the IOM report was to get people thinking differently about pain. The key paradigm shift that comes out of that is that we've got to understand that chronic pain is not just a symptom of a problem. It is in fact a disease in and of itself. And that's a big deal. We need to understand that when you are going after trying to treat something, if you view the chronic pain as merely a byproduct of something else that's going on, especially if it's a peripheral pain problem, then you really don't get to the fundamental problem, the fundamental issue that's causing that in the first place, and that's been a failing in medicine. We are just now kind of catching on to this. Let's talk about some chronic pain conditions. Just make sure we're on the same page in terms of what are we talking about here. So we take, for example, idiopathic low back pain. Idiopathic means we don't know why. There's no specific pathology known. And this is a very, very common problem, very common in middle-aged people like myself, and as you get older it tends to become more and more of a problem. It's that low back pain, mid-back pain that in some people becomes completely debilitating. Chronic headaches, tension-type headaches, migraine headaches, you name it. There are people that deal with headaches almost on a daily basis of their entire life. Temporomandibular disorders, TM joint diseases, those kinds of things. Irritable bowel syndrome is another very common and actually growing in incidence chronic pain problem. Osteoarthritis and rheumatoid arthritis. I'm going to talk a little bit more about these specifically, and you're going to find something very interesting when we start talking about osteoarthritis. I think it's going to surprise you. And another condition, fibromyalgia. This is one that I specifically, was my lead-in becoming interested in chronic pain. This is a chronic pain problem that's been around. This has been in the medical literature now since the mid-1700s, and until just very, very recently, any piece of work that you saw in the medical literature that talked about this particular condition, which is, by the way, a condition of just full body pain that's unremitting. It is a relentless day-to-day, you're going to have it the rest of your life, pain problem. It is the type of pain problem that a simple touch like that can make a person scream in pain. And I have seen that many times in clinic. It is not a joke. But if you looked at it in the medical literature up till just very recently, medical literature always talked about fibromyalgia as being one of those, well, that's just a psychological problem that women have. And seriously, oh, I'm going to tell you more about that. Turns out it's the key to figuring everything out. You're going to see why in just a few moments. 10 years ago, when I first got into this particular field, 10, 15 or so years ago, I read papers about this disease called fibromyalgia, and it was constantly called a mysterious illness. I alluded to it being thought of as a psychological problem. It's a disease that the incidence happens, it's about a 9-to-1 ratio. It happens more in females than it does in males. And it was very, very common to see people in medical science write this one off as just a nutty women disease. Seriously. Papers up till just a couple of years ago, every paper that I ever read in the medical literature always started off with things like, fibromyalgia is a poorly understood condition. It is just in the last year or so, though, that papers coming out today, the research that's being published today, is now calling it the prototypical central pain condition. And that central pain concept is really important for us, folks. I want to talk about fundamental pain models. There are 3 fundamental pain models that are out there in terms of understanding why do we hurt. The first one is the activation model. The idea that when something happens to us, if I take a hammer and I whack my finger, for example, there are pain pathways that are going to be activated by peripheral pain stimuli. If I hurt myself, I am going to feel pain. It's always been believed, too, that the amplitude and duration of the pain was going to be determined entirely by, effectively, the intensity and the timing of the peripheral input. So my pain when I whack my finger with a hammer is going to roughly coincide with whacking my finger with a hammer, is what that basically says. The problem, of course, is that once you stop, if you can manage to stop hitting your finger with the hammer, the pain's going to hang around a little while. And some people, the pain doesn't go away. So the activation model doesn't quite cover all of the spectrum of why are we hurting the way we're hurting. Brings to mind another model. This one's not a very popular model, so I'm going to kind of breeze through this one really quickly, but it's the gating model, the idea that there are gating controls in our central nervous system that can basically selectively turn pain on and off in people. It is what it is. There's not a whole lot, Craig, not a whole lot to this one. The new model, though, that has literally emerged in the last 20 or so years is the concept of centralized pain. Pain that specifically results from neuroplastic changes in the functional properties of the central nervous system. Central pain essentially says that something's going on in our central nervous system, specifically in our brains, that causes us to relearn effectively how we perceive pain, how we process pain. Because it's a neuroplastic process, the idea here then is that once you go there, once you have centralized your pain, it may not be reversible. And that's why we're starting to think this is why people get into a chronic pain pattern where whatever's going on in the periphery may resolve itself, but there's still a pain issue here. So we're going to take a closer look at the central pain paradigm. It really starts with, at least this is the thinking right now, that it generally starts with some sort of an episode in life of a prolonged pain exposure. You throw out your back, for example. This happens to people all the time. The first time it happened to me, just to give you an idea, I was picking up a garden hose, and the next thing you know, I was trying to pick myself up off the ground, and I was failing miserably at that. That lasted for a good 3 or 4 weeks. That was a prolonged pain exposure. In my case, got over it in time, and all's good. I didn't have any prolonged, lasting effects. But we know that in some people, it doesn't quite work that way. Or if you have repeated episodes of something like this, or also, very importantly, too, there may be certain genetic predispositions, predisposing factors involved. We don't know quite yet exactly what those are or how that might work. We just know that there are hints in the data that tell us that kind of thing. We also know that other stressors in life may also be predisposing factors for something like this. People who undergo or have lived through very, very stressful events in life tend to find triggering in those events. For example, I have a friend who has fibromyalgia or had fibromyalgia, and in her case, she was a perfectly normal person. Her mother had a car accident one day, and the stress from that car accident put her into a state of chronic pain for years. You know, it was just that stressor in that particular case. So something goes on. We get some sort of stresses, some sort of life stressor, prolonged pain exposure. Over time, if that doesn't resolve, though, we start developing this thing called central sensitization. And central sensitization is just easily thought of as a cyclic type of neuroplastic change in our bodies and our central nervous system that lead us to develop in the pain processing pathways an amplification mechanism, an amplification and a perpetuation of I should have used the word growth actually, growth of neural pain processing pathways. They increase. We get more and more of these network connections that are not supposed to be processing pain, but all of a sudden they are processing pain. And once that happens, then we say, okay, the person's in a state of central sensitization. The result, reduced pain threshold. Reduced pain threshold essentially saying that things that normally hurt us just a little bit, now all of a sudden they hurt us a lot, and they keep hurting a lot. On top of that, we get a heightened response to minimal stimulus. I used this example a few moments ago. Tap yourself on the lateral epicondyle. There's a nerve there, by the way. Tap yourself on that lateral epicondyle area. That doesn't hurt one bit. You can do that all you want. At least in me, you can. But if somebody has centralized pain, where that nerve processing pathway now, that neural processing pathway, is now heightened in its sensitivity, this nothing all of a sudden becomes something because the brain isn't perceiving it as a nothing. The brain and its pain processing pathways are perceiving it as this is a major pain-causing event. And when the brain processes pain or those kinds of inputs that way, we feel pain. We feel it even though there's nothing wrong at all. You can even get pain sensations completely in the absence of a stimulus. Nothing's causing any painful sensation, yet the brain can spontaneously process any kind of a nerve input and treat it as though it's painful. So this central sensitization thing, this is an issue. This is the fundamental problem, we think, in terms of central pain. What's really going on here in these folks? Neuroimaging here. I'm showing you a couple of neuroimaging examples. One's from a functional magnetic resonance imaging study that was done on fibromyalgia. Just to give you an idea. And I know the picture's not that big. I probably should have made it bigger here. But as we look up into these 2 rows here towards the bottom, we see this yellow, this kind of lighting up, if you will. Those particular areas that are lit up in the brains of the fibromyalgia patients happen to be in an area of the brain called the somatosensory cortex. In the somatosensory cortex, this is where the brain processes all the general inputs coming in from the body and makes a determination of what to do with them. It processes an input. Something's happening. I've whacked my finger, for example, with a hammer. The first thing that happens in the brain is the somatosensory cortex essentially analyzes and figures out what could be wrong, and then it broadcasts out to the other parts of the brain We have a problem, we need to do something about it. Here we see in this fMRI image that compared individuals, healthy, normal individuals, the fibromyalgia patient's somatosensory cortex to just a trivial pain input lights right up. If you did this exact same thing in a person that does not have centralized pain, you won't see anything at all. There's nothing going on there. It's just a trivial response, if any at all. So this is essentially the face, the picture, if you will, of central sensitization. This is the brain overreacting. We actually can also see it as well. This is using electroencephalography. This is actually from some data that was developed in a study that I did a couple of years ago. We're using electroencephalography in this case and looking at neuroactivity, the electrical neuroactivity, not using, obviously fancy fMRI imaging, but you'll notice here that based on the red images here that you see, we're seeing the exact same problem in the exact same areas. We think this is also evidence of the central sensitivity fingerprint, if you will, and we're going to come back to that image in just a few minutes. So, central pain paradigm, this, folks, is a big deal. As a matter of fact, there's another really good, simple way of looking at it. Central sensitivity is merely like turning up the volume control of pain. The higher the volume control setting, the more pain we're going to experience regardless of peripheral nociceptive input. In other words, when pain is has centralized, it no longer matters what's going on out here. Now this is the thing that's in charge of your painful life. Now, we've learned this only in the last few years when it comes to fibromyalgia. Again, a few years ago, this was a joke disease. This is what a lot of physicians call the wastebasket diagnosis. All of a sudden, though, this little mystery condition shows itself to be, well, this is a central pain problem. Now we start to see what the pathology is here. We start knowing what's going on. And that little mystery condition started opening up a bunch of doors. It got researchers to look at other chronic pain conditions and see, well, you know, in fibromyalgia, there was never anything wrong out in the tissues, yet these people are hurting like crazy. That was a central pain problem. Well, what about things like idiopathic low back pain? What about things like osteoarthritic pain where there's really nothing wrong in the tissues, but they're still feeling pain like there is? Could that also be a central problem? Well, one of the answers to that starts with, was there any correlation whatsoever between the degree of tissue damage or inflammation in the periphery? In other words, the nociceptive inputs. When people have, for example, low back pain, is there any relationship between what's going on out there in the periphery and the pain that they're actually experiencing? Answer: none whatsoever. There was no correlation at all between that. So, as a matter of fact, there's no chronic pain state that's been figured out yet where there is any relationship between what's happening out here and the pain that those people experience. Yet, if you think about this, our diagnostic paradigms and actually the terms that we use to describe chronic pain states kind of tells us otherwise. We talk about low back pain. Back pain. That's the problem's in the back, right? No. The problem's not necessarily in the back. Irritable bowel syndrome, something's wrong with the intestinal tracts, right? Not necessarily. See, central sensitivity and the centralized pain paradigm is moving us away from thinking in the periphery. It's got us thinking about what's going on up here instead. Not very long ago, just literally a few years ago in all the chronic pain states, the disparity between peripheral findings and pain was believed to be a psychological problem, psychosomatic issues in these people. Today, we now know that central sensitization really is playing a very prominent role in developing and perpetuating chronic pain. Bottom line for us, it turns out that the work that researchers have been doing for the last now about 20 years in understanding the central aspects of fibromyalgia has taught us that we have been looking in all the wrong places for the answers to other chronic pain conditions. Our current paradigms for diagnosing and treating chronic pain are just instantly antiquated. The IOM report of 2010 revealed that. We now know that we've got to move away from our thinking in chronic pain. Just to give you an instance of what I'm talking about here, I want to consider osteoarthritis. This is the most counterintuitive thing when we think about osteoarthritis because we all know that osteoarthritis is the classic peripheral pain problem. If I get an arthritic knee, for example, why, the pain is due to what's going on in the arthritic knee and the inflammation there that's involved with that. Yet think about this, folks. A person that has an arthritic knee for a very long time, let's say the right knee is bad. Let's say that the left knee is perfectly fine. There's nothing wrong in the left knee, but due to injury or whatever, let's say the right knee is bad. In the early going of that problem, it'll be obvious and common that the person should expect to experience pain if spontaneously from the knee, or if you palpate it or move it around a little bit, you're going to feel it. Wouldn't expect to feel anything over in the left knee now, would you? Because there's nothing wrong there. Yet, if left untreated and over time, that person who's experiencing or has osteoarthritis in the right knee, it is very, very common for that person to eventually start feeling the same pain if you palpate the left knee. And there's nothing wrong there. There's nothing wrong in those tissues. So the question becomes, why? Why would a person who's got a bad knee on the right-hand side feel the same pain if you palpate the good knee on the left-hand side? It turns out that maybe it's not just a peripheral pain problem after all. It turns out further work has showed us that there is actually a very poor relationship between the structural abnormalities, the problematic joints in osteoarthritis, and symptoms. As a matter of fact, get this. Turns out that when you look at OA in general, that about 30 to 40% of individuals who actually show radiographic osteoarthritis have no symptoms whatsoever. In other words, the x-rays tell us that's a bad joint, that should be hurting. Doesn't hurt at all. 30 to 40% of people are that way. 10% of individuals that have all kinds of severe osteoarthritic pain have perfectly normal x-rays. You can't see anything wrong on the x-rays. What's that telling us? That we just missed it? No, not at all. Psychological factors, notice I keep cycling back around this psychological factors thing. They don't explain the problems. It's not a psychological issue. Current therapies that we have right now for osteoarthritis, the frontline therapies are your typical NSAIDs, ibuprofen, for example. Acetaminophen is used as well. It turns out that a recent study, actually a meta-analysis study of a bunch of studies, showed that when you look at the difference in pain relief for people taking the frontline type NSAID type analgesics, the difference between pain relief on a 100 millimeter visual analog scale, going from absolute worst pain imaginable to no pain whatsoever, the difference between taking the medicine and placebo was only 4 millimeters. In other words, they are barely, if at all significantly, better than just taking a sugar pill. Opioids are often used too, especially when the arthritis has been there a long, long time and it's becoming much, much more problematic. Difference between placebo and opioid therapies, 8 millimeters on the 100 millimeter visual analog scale. Hardly anything in terms of any benefit. We're not even touching it. Now, you want to see the scary part? Check this out. Let's just talk about knee osteoarthritis only. It's common. Obviously, we know that this is a problem that a lot of people have. The common late-stage therapy, of course, is total knee arthroplasty, knee replacement. Yet, studies are now showing that for all the expense that goes into knee arthroplasty, replacing people's knees, it turns out that somewhere between about 20 to 40% of people that undergo that surgery are still going to have very significant and severe pain a full 1 to 2 years out after the replacement's been done, after the healing has ostensibly taken place. If you consider the population demographics, the aging population, the growing in size population, there are estimates out there right now from studies that tell us that the demand for knee arthroplasty is projected to increase a full 700% by the year 2027, 15 or so years from now. And it turns out that if we think about the increased cost that's going to come along with that, one report suggests that unless we come up with new ways to assess and treat and identify who's going to respond to a knee replacement, that, and again, I put this in quotes because this is from the study, I'm not saying this, that knee osteoarthritis alone, just knee osteoarthritis alone, will break the Medicare bank. It's a huge problem looming in the future that's going to sneak up on us if we don't figure out a way to deal with the pain problem. So now we come to the question of centralized pain and osteoarthritis. The question then becomes, well, could the central pain paradigm provide the answers? Is it possible that the poor efficacy that we see in the common meds is because we're not treating the central problem, that we're treating the peripheral problem, we're trying to treat inflammation where the actual issue is more of a central pain problem? Does that explain why OA doesn't correlate to structural findings, and will this possibly explain the poor response associated with knee replacement? Well, here's another fMRI study right here, and this was from an osteoarthritis study, and check this out. Once again, we see almost in the exact same areas that we saw in the fibromyalgia case, we're seeing a central sensitivity problem. It turns out that the problem in OA, for those people that don't respond well to the typical medications, it's not because of the peripheral problem, it's because of the central problem. And all the time that's been spent on trying to deal with the inflammation and the problem in the joints, we've been missing the picture altogether. Neuroimaging studies and technology has showed us that in addition to OA and fibromyalgia, central pain is now known to be relevant in chronic back pain. We see it in chronic back pain, we can see it in chronic headache, and we even see it in irritable bowel syndrome. So all the common chronic pain conditions that we talked about earlier on, central sensitivity is important. Those neuroimaging studies show us that CS is actually the key factor in maintaining the chronic pain. And here was something that I think is rather eye-popping. Central sensitization and measures of central sensitization is in fact the only thing then that correlates well with the increased pain perception and quality of life in chronic pain. What's going on in the periphery, and I talked about this earlier on, it doesn't correlate at all with how people feel pain. But the central sensitivity part actually maps up to it very nicely. So we know now this is the big deal. The question becomes, well, fine, what are we going to do about this? Well, there are two areas, and these were identified in the IOM report, two areas that are becoming very, very important. We've got to find diagnostic and assessment techniques or technologies that allow people, especially at the point of care, at the general physician's office, to identify when the pain that their patients are feeling is a central pain problem versus a peripheral pain problem. If we can find early on who's dealing with central pain and who's not, then that changes the way we go after therapies for these folks. And on top of that, then we're going to have to find safe and effective centrally acting therapies that are frankly better than the ones that are out there right now. Existing drugs, and there's a handful of them that are centrally acting, moderate efficacy at best, and they've got some pretty nasty side effect profiles. So just the mere fact that we're figuring out central sensitivity as an issue doesn't mean we got great ways to treat it. So with that, I'm going to transition, and I realize our time is moving along here. I'm going to transition now into some of the areas of work that I've been doing, just kind of give you an overview of some of the stuff that I've had going on here in the past few years. And as Terry mentioned, I'm doing this in collaboration with a lot of individuals in the field who are very strong in chronic pain medicine. First of all, we've got to come up with diagnostic technologies. Point of care technologies especially. You don't want to have situations where people are in chronic pain and they've been dealing with pain for years before every test has been exhausted and finally the physician just throws up his or her hands and says it's got to be a central pain problem. We need to know that right up front. We need to know it right away. We can see it. We can see it, as you guys saw earlier on, with technologies such as functional magnetic resonance imaging or PET scanning. But these technologies, not only the scanning part, but the work it takes to analyze the data and actually figure out what's, what it's showing us. Extremely expensive, folks, extremely expensive. So that's not going to be the answer. But I showed you a graphic a few moments ago looking at electroencephalography, EEG, as possibly a method that might be used to identify something called cortical network connectivity. Now, cortical network connectivity or network connectivity is merely a cortical measure that, and I'm explaining this in a little bit more detail in just a moment, but it is something that correlates very, very nicely with pain severity and, very importantly, just emerging in the past few months, the degree of network connectivity that people in pain have actually correlates nicely with improvement. So in other words, when people actually receive an efficacious therapy and they get symptom improvements, it turns out there's a nice relationship between that and reduction in enhanced network connectivity. So this becomes an important thing. So the question then becomes well, can we then use EEG as potentially a much less expensive way of identifying this thing and making it practical at the point of care? Well, it turns out there is a measure in EEG that may do just that. It's a measure called coherence. Now, coherence is merely a measure of the phase and amplitude correlation between pairs of EEG electrodes. I'm guessing most of you have probably not seen an EEG done. When an EEG is done, a number of electrodes are placed on your scalp. You don't have to have your head shaved or anything because there's, I know a lot of people are like, good. It's the first question we usually get in clinic. Electrodes are placed on the scalp, nothing pierces the skin, totally non-invasive, but using very, very sensitive electrical instrumentation. Each electrode measures the very, very tiny voltage that's generated at the cortex and passes through the skull. When I say tiny voltage, we're talking about millionths of a volt. Picking that signal out of the mud is extremely, extremely tricky, but it's doable. And depending upon the number of electrodes that you use, you see more and more detail about, well, what's going on directly under that electrode in terms of electrical activity in the cortex. Typically, a typical clinical EEG might have 19 to 25 different electrodes. A high-density EEG might have 64, 128, even more electrodes. So you got a whole bunch of measures here. When we talk about this coherence thing, all that is saying is that if you took a look at the electrical signal, let's say I had an electrode right here on my head, and it's measuring an electrical signal from that. If you look at an EEG signal, it's just a squiggly little line of electricity. If you took a look at that, and let's say you had another electrode back here, and if you saw an event, an electrical event in the cortex right here, if there's a network connection between that part of the cortex and other parts of the cortex, you will see similarity in the signal that's measured here and in other locations. If we see, for example, a little blip in that signal here, if you see that same blip or something like that in another place in the brain, that means they're talking to each other. There's a network connection. And that's all coherence does for us. It just gives us an idea of what portions of the cortex are talking to each other. It's a simple concept, but it turns out that it's actually the most temporally stable way of measuring network connectivity. We can see network connections using fMRI. The only problem with fMRI is not only is it very expensive, it just gives us a little snapshot in time and what's going on. When we use EEG, though, we can see stable networks over time because EEG is very temporally sensitive. Now, there's an image, as you see right here. This image right here is a simple EEG coherence image. You see red lines here, a few blue lines connected between the dots. Those red lines, in this particular case, this is from work that was done where we're looking at EEG coherence, where we took a look at a bunch of normal controls, a handful of normal controls, people that don't experience any kind of specific pain issues, and we stimulated them in a way to cause some pain. A little thumb smashing will do the trick. Sorry. Anyway, the normal controls, the red lines here, these indicate places where there were significant, statistically and clinically significant increases in coherence from the minutes before the painful stimulus and the minutes after the painful stimulus. And we see here in the healthy normal controls, there was really very little change. There's not a lot going on right here. These are actually 19 EEG connections. And if you look at all the possible relationships between the pairs, there's 171 possible connections going on here. And we see just a very small handful. As a matter of fact, over here in the alpha range of EEG, that's the EEG that typically has frequency components in about the 8 to 12 hertz range. This is active, alert EEG. We see that this is probably the place where you might say, well, something went on here. There was an increase in network connectivity. There was some sort of processing that took place. We see it in this, and we also see it here in these frontal connections. This is the prefrontal cortex. This is actually where pain does get processed after it leaves the somatosensory cortex. So in other words, this here, folks, this was absolutely no surprise. That was the healthy normal control group. Now we did the exact same thing in a group of patients with fibromyalgia, and keep in mind, fibromyalgia is the prototypical central pain problem. We know that their issue is central pain. We did the exact same thing with these folks. We applied just enough pressure, just enough thumb pressure to cause the patient to say, that hurts. Now to give you an idea, if you want to get an idea of how much pressure that is, if you press on your thumb enough to blanch it in a way that it makes the tissue under there looks white, that shouldn't bother anybody in here. I mean, it shouldn't. It may bother some, but generally speaking, that's not a painful problem. In the case of a patient with fibromyalgia, you don't even get anywhere close to getting any blanching of the thumb, and they are in pain. So it doesn't take a whole lot of pressure. But in that case, they experience the pain. And this is what their EEG coherence looked like. This was the changes in their network connectivity before the painful stimulus, in the minutes leading up to the painful stimulus, and in the minutes afterwards. We just looked at 3 or 4 minutes pre-post, and looked at the changes in their coherence. They lit up. The networks in the brain just went berserk. Classic indication of central sensitivity. And we're seeing it with nice, simple EEG. Diagnostic and assessment implications, if we can, this increase in coherence, it appears that it indicates abnormal functional network connectivity consistent with central sensitization, as I spoke of. If validated, this test could certainly lead to inexpensive diagnostic methods that could be used in first-line physicians' offices, because whereas an fMRI can cost anywhere from $10,000 to $20,000 depending upon what you do with it a piece, you can do EEGs all day long for a couple $100s. Identifying centralized pain early on would give all sorts of, it would guide treatment approaches, reduce healthcare costs, and most importantly for the patient, time to benefit. That time between the first trip to the physician's office, doc, I'm in pain, to maybe getting something out of it, which in a lot of chronic pain cases is many years before they actually get results. If we could identify the centralized pain right away, it tells us where to look to treat. And that's a very important piece. Another area of research I've been involved with, folks, is neuromodulatory therapy. Now, the whole idea here, the goal of neuromodulatory therapy is to use electrical signals that actually target and modulate abnormal cortical networks. And this is not anything really new. There's actually a lot of research and commercial work that's being done to develop technologies in this area. For example, Medtronic, a company out of the Minnesota area, Minneapolis, Minnesota area, they have a very large business arm and implanted neurostimulators where they crack open the skull, drop a stimulator in there, and try to manage pain, manage Parkinsonian tremor, those kinds of things. There's a lot of work going on in this area right now. I'm very interested, though, in the quest for, can we do this thing non-invasively? The problem, though, when non-invasive neuromodulatory approaches is very simple. Your skin, your skull, it does not like to conduct electricity. So the question then was, how do we overcome that? Well, an area that I've been working in is signal modulation strategies, where we can modulate neurostimulatory signals in a way that we can transmit the therapeutic signal components across the intervening tissues, the tissues that don't conduct very well, skin, skull, get that signal into the cortical tissues where we can do something good with it and actually target specific cortical tissues without significant loss. That's been the trick in non-invasive neurostimulation or neuromodulation, and that's the area that I'm involved with right now. A particular technique that I was involved in developing has already been tested in a study that we did up at McLaren a few years ago. It was a randomized, double-blind, and sham-controlled study. It was actually done at McLaren and Genesis and involved 77 fibromyalgia patients. Took place from 2005-2008. Now, one of the things that we wanted to see from that study is, did we in fact have any kind of an effect on network connectivity? That's, at the end of the day, this is what it's all about. The mechanism needs to be known. You saw this image earlier on. This particular image here was a lot smaller previously. This is a typical fibromyalgia presentation. This is fibromyalgia patients. As a matter of fact, this particular patient was one who had had the condition for 12 years, had tried every medication out there. Full body pain, fatigue, over 12 years, no successful treatment. This is actually, as I mentioned earlier on, this is the EEG. This is a source localization code that's used where you measure the EEG and work the inverse problem to figure out where the problem, where that EEG signal actually emanated from. This is what the patient looked like before the neuromodulatory treatment. Again, we see that very characteristic problem back here in the somatosensory cortex, the motor cortex area here, that's indicative of the central sensitivity abnormality. Using a neuromodulatory, non-invasive neuromodulatory treatment paradigm, though, that patient, after one course of treatment, this is the exact same imagery where we're looking at the EEG inverse tomography image here, and you see there's no red. The problem that was there before is completely went away, completely resolved. This is the same patient now after that course of therapy. As you see, the central sensitivity problem gone. This is one of a handful of patients that we still track over time. This person's now 5 years post-therapy, actually approaching 6 to tell you the truth, and she's had no return of symptoms or any indication of any problem whatsoever, totally pain-free. So the idea here is, and the question then becomes, can we use these kinds of technologies to actually target and find the specific cortical tissues in a way that we can resolve that abnormal network connectivity that we see? Can we break that network connectivity up? And in doing so, does it resolve it in a permanent way? That's the big question of what we're trying to do with this particular arm of clinical research. This stuff, by the way, has been published in the medical journal Pain Medicine as of last year. Just to give you an idea, and I know we probably don't want to dig into the mud of all the numbers right here, folks, but just to give you an idea, these are a comparison that was done here between these neuromodulatory approaches, and 3 drugs are approved right now by the FDA for the treatment and management of fibromyalgia, one being duloxetine, that's Cymbalta, pregabalin, which is Lyrica, and meloxicam, which is Savella. These are only 3 drugs that are centrally acting and approved for these kinds of therapies. And as you can see here, just looking at the neuromodulatory report and looking at changes, for example, the number of subjects, or the percentage of subjects that had at least a 30% pain relief, which is a responder level. We see that the neuromodulatory level was right on par with duloxetine, a little bit better than pregabalin and meloxicam. Fibromyalgia Impact Questionnaire, which is an internationally validated tool for figuring out how these people are affected by their disease. We can see here that actually the neuromodulatory approach was numerically superior to the medications. We see the same with the pain VAS, fatigue VAS, sleep visual analog scale, and actually number of tender points, which is a measure of tenderness, neurosensitivity, if you will, superior in this particular case. So you look at this data and it might suggest that, okay, well, it's at least on par with the medicines, and maybe in some areas maybe a little bit better. But what really jumps out at you, though, is we saw no serious adverse effects with this therapy whatsoever, and only mild side effects. About 5% of patients get headache and nausea, and it just resolves spontaneously. There's no therapies needed for that. So pretty good study outcomes. But the thing that really jumped out and is really, really causing some eyes to open up is early this year, we published a paper that looked at long-term outcomes in those patients that were treated back between 2005 and 2008. In this case here, we were looking at an average of 45 months follow-up, and it was in the treated arm only. There was a sham arm, as I may or may not have mentioned, but we didn't look at folks that received sham. We just looked at the treated arm only. They were unblinded this time. But what we saw here at the nearly 4-year point was that the vast majority of patients, and when I say that, we're talking about 80% or so of patients, reported improvements in the key symptom domains of pain, fatigue, sleep, depression as well, and depression and mood in this case. Improvement lasting at least 2 years, and about 60% of the patients are reporting that their improvements are still ongoing. So very successful in the long-term sense. We also looked at this thing called the Fibromyalgia Impact Questionnaire, the FIQ. That's it's a survey essentially that takes inventory of their pain, all the other symptoms that they have and their effect on life. What we found was something really remarkable, that the FIQ results at the follow-up correlated magnificently with the end-of-study outcomes. In other words, we looked at where these folks were at baseline and how their FIQs improved from baseline to end of therapy, which, by the way, the therapy lasts about 11 weeks. It's a 2-day-a-week process, in and out, repeat applications model. We looked at improvements from baseline to end of study, and then we looked at baseline to long-term. And it turned out that those changes correlated at a R level of about 0.8, meaning that it was very indicative that folks that got better after therapy stayed better over time. If they didn't get better after therapy, they didn't magically get better 4 years later. That's what that's really telling us. It gives us visibility to the idea that early results might be a predictor of long-term outcomes. But the thing that really was exciting too is that 76% of the patients that were surveyed then in that follow-up reported that they have either completely eliminated or significantly reduced their need for pain medicines for fibromyalgia, and 71% reported either reduced or completely eliminated caregiver visits for fibromyalgia as well. So that's eye-popping in terms of, especially when you consider the cost of this particular illness and the burden it has on our healthcare system. That, folks, is about it. In summary here, central pain, this is a big deal. It's the primary paradigm right now in chronic pain. We know network connectivity is the big deal. We're seeing evidence that there's a potential biomarker buried in that. The lower cost EEG is something that may emerge as a point of care diagnostic. The neuromodulation therapy, as we see now, may be a modality that could at least be thought of as an adjunctive therapy, if not potentially a first-line therapy, and may cause lasting symptom reduction. Some things that are emerging, just to give you some ideas of some of the work that I intend to be involved with going forward. Of course, developing the EEG coherence concept and the data, it's confirming not only the mechanism, but I think this is where we've got a chance at a POC diagnostic. And something else, a group I'm working with right now down at U of M, they're actually working to identify specific network hubs in these networks. It's a fascinating concept. It's the idea, and you saw, if you go back to those coherence images where we saw those lines going all over the place, There's an idea out there that networks, though, work in like a hub system, like airports, for example, have hubs. So Detroit's a hub to Flint and Lansing and all these other places. And so the idea here is that whereas you might be able to use a neuromodulatory approach by just, just kind of a random hit these cortical tissues, if we can learn where the hubs, though, are, that are kind of the first processing of these pain signals, and take out the hubs, then you deactivate the entire network. And that obviously would optimize therapy and do, we think, a whole lot better. So we intend to be going there soon. That's it, folks. Thank you. Any